Hello, thank you,
Hello,
Alyssa.
thank you, Alyssa.
So welcome to the
Welcome
webinar.
to
My
the
name is
webinar. My
Mazin
name is
Boushakra
Boushakra
again, and
again,
I'm a
and I'm a
clinical
clinical
pharmacist here at
pharmacist here
AHC.
at AHC.
Today I'll be
Today I'll be
presenting an
presenting
overview of
an overview of
hypertension.
hypertension.
I hope you guys enjoy the program and learn some interesting facts along the way. So as you can see, there's the cardiovascular system up on here. We're going to start by noting that I do not declare any conflicts of interest and that all the images and graphics and figures on this presentation are displayed for educational purposes only. So what will you learn from this presentation? So some of the objectives that I hope you guys know by the end of this hour will be, I hope you understand the physiology and the rate of occurrence of hypertension, as well as some of the consequences of having this high blood pressure. Thirdly, I hope to elucidate this concept of myocardial oxygen demand and myocardial oxygen supply. And lastly, treatment options used to treat hypertension. So we're going to be going through this EKG strip here, and we'll be starting at the beginning, and we'll move our way all the way along to the end. So I first want to start out with a pretty big question, okay? And that question is, as human beings, what kills us in the world? What is harming us? So this graph is from the World Health Organization, and it shows the top leading causes of death in the world in the past decade. Okay? As you can see, ischemic heart disease is the #1 top killer, and it killed about 77.4 million people in 2012. So your next question would be, well, what puts us at risk for ischemic heart disease? How do I get this condition? How does this happen to me? Well, the next slide is risk factors that are associated with death, risk factors that lead to death. And as you can see, given the title of this presentation, high blood pressure is among the leading causes, followed by tobacco use, high blood glucose, physical inactivity, and overweight and obesity. So all these things are responsible for raising the risk of chronic diseases. On the bottom y-axis here, you'll see mortality in the thousands, and we'll go into what these colors mean in a second. So how are these causes related? Are these indirect causes? Are these direct causes? This graph, or this slide, shows something called the causal chain. And what the causal chain basically represents is pathways by which all these causes interact. So as can be seen from this example, and ischemic heart disease being, of course, the leading cause of death, we see that type 2 diabetes, high cholesterol, and high blood pressure are all relatively direct causes because the arrows are directly going to this ischemic heart disease box. Whereas some of the other factors located further away down the causal chain or further back in the causal chain act as indirect causes, things like age or education level or your income status. So speaking of income, that should be your next question, right? Somebody's going to say, well, doesn't income have an effect on some of these risk factors? And this graph is another graph by the World Health Organization. And what this shows is risks by income level. Because income level may affect or influence these risk factors, this figure shows countries which are grouped by gross national income per capita. As you can see, high blood pressure is indiscriminate of this. We see the low income bracket. This population is most affected by risk associated with poverty, which makes sense. Things like undernutrition, unsafe sex, unsafe water, poor sanitation and hygiene, etc. However, high blood pressure does still remain high up on that list. And when we go to the higher income group, we see high blood pressure also high up on that list, followed by overweight and obesity and physical inactivity. Moving along. So my next question for you all is, what really is blood pressure? What does that really mean? So to understand that, we need to go into some of the physics don't let me lose you guys here, okay? I'm going to take 1 minute to explain this, and this will help you guys understand what exactly is happening when we talk about this concept of blood pressure. So recall that any real fluid has a certain viscosity to it, meaning it has a certain internal friction that is a result of the electrical forces between the molecules and atoms within that fluid. If we take that fluid, in this case our blood, and we place it in a cylinder, or in this case a blood vessel, the internal viscosity of the blood helps generate the pressure to propel it through the vessels of our body. Makes sense. An equation exists called Poisson's equation, and this equation basically helps us understand fluid moving within a vessel, whether it be a pipe, whether it be a blood vessel. And from this equation, we can see that blood volume flow rate on the left here is equal to the product of pi times our radius to the fourth power. Remember that fourth power, where the radius is simply the area of our cylindrical tube multiplied by the pressure gradient at point 1 and point 2, divided by the viscosity, this little n-looking symbol here, times the length of our vessel. So something that I want you guys to notice right away, and that's what that circle is here for, is that our flow rate is directly proportional to our radius of our vessel. What that means is if we decrease the radius of our cross-sectional area, i.e. our vessel, then we decrease the volume flow rate because the volume flow rate, again, is directly proportional, as you can see from the equation. So, my point is this. If we take our radius of our vessel and we divide it by half, you see vessel 2 and vessel 1, we are decreasing our volume flow rate not by 2, but by a factor of 16. Can you guys all see that here? Because our radius is raised to the fourth power, 2 to the 4 is 16, therefore our volume flow rate is divided by 16. So if you can see here, when we decrease our cross-section area by half, we are really decreasing it by something much larger. What does that mean? That means that a larger pressure gradient has to exist to maintain the same volume flow rate. Who generates that pressure? The heart. So where is this applicable? In this process called atherosclerosis, right? We literally have plaque and fatty buildup in our arteries, narrowing our cross-sectional area. And to keep that same pressure going, we don't increase our pressure by 2, we have to increase it by a factor of 16. So a huge and immense gradient needs to be generated to overcome this hardening and buildup of plaque in our arteries and to maintain this flow rate. So let's go back to our question. So blood pressure is this flow rate pushing up against our vessel walls. That's what blood pressure is. Hypertension occurs when the arteries experience persistently, italicized, elevated pressures, which leads to damage to our organs. So again, what causes this? How is this process happening? This high blood pressure issue. How is this happening? Well, the answer is we don't really know. There's no really identifiable cause. And 90% of the cases of hypertension have no recognizable identifiable cause. And this is called primary hypertension, which is separated into two types, primary and secondary. This first type, again, has no identifiable cause, but we have factors associated with the condition, which is really important because we can look at those factors. What are those factors? Overweight and obesity, sedentary lifestyle, physical inactivity. Right away, having a sedentary lifestyle, it makes sense that this is such a detrimental condition. Why? Because our bodies are made of mostly muscle, right? We're built to move. And when we try to go against that, our body responds in a very, very negative way. And I have this little picture here again of this plaque buildup, this process of atherosclerosis over time, causing our vessels to deteriorate, our area to decrease, our heart has to work harder, and this happens persistently and consistently. Other factors include too much alcohol, using tobacco, too much salt in your diet, etc., etc. So we have a name for the co-occurrence of these associated risk factors, and that name is metabolic syndrome, also called syndrome X. Unfortunately, most Americans have this issue. As you can see, if you fulfill any 3 of these 5 risk factors, you are characterized as having this metabolic syndrome, this disruption in your physiology, something that's really so important to life. So we can go ahead and qualify these measures. The ATP3 guidelines have done that, and this is just qualifying what abdominal obesity means. What does it mean to have abdominal obesity? Well, if you're a male and your waist circumference is greater than 40 inches, then that's characterized as satisfying one of those categories. If you're a female, greater than 35 inches, and if you have high triglycerides, etc., 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 and fulfilling any 3 of these 5, boom, you have metabolic syndrome, according to this expert panel. So let's move right along. What's the second type? The second type is secondary hypertension. This is more, very, very small amount of people have this. This is maybe about 5%, whereas people who have primary hypertension is about 95%. So in the secondary hypertension, these are identifiable causes. We know identifiable causes. We know what's causing this. Things like CKD, drug-induced problems, thyroid diseases, all these things we know directly can cause hypertension. We can pin it down here. So let's move right along, get this EKG here. So what's the prevalence? Well, 1 in every 3 adults has high blood pressure. That's about 67 million Americans. And only about half of those who have high blood pressure have their blood pressure under control. For those who don't have hypertension, 1 in 3 of them have prehypertension, meaning their blood pressure is not high enough to be characterized as hypertensive, but it's trending towards that normal range. The cost of hypertension is almost 50 billion per year, and this is going to become important later at the end when we talk about this thing called the big picture. So I'll let you guys digest that as we go into the diagnosis and evaluation. So I really like this part because, especially when we go into this diagram here, because it kind of helps you put a number on what these numbers mean. So when we talk about blood pressure, it's normally reported like this top number over the bottom number. What do these numbers mean? We have the top number, which means the systolic pressure, and the bottom number, which means the diastolic pressure, measured in millimeters of mercury. So what does that really mean, millimeters of mercury? Well, when the heart contracts, it needs to generate a pressure to expel fluid out of the aorta into the body. That pressure is about 120 millimeters of mercury. What does that mean? Well, let's say everybody knows what a square inch looks like, right? Everyone knows what an inch is. 120 millimeters of mercury is if you take that square inch and you apply about 2 pounds of pressure on that little area, that's what 120 millimeters of mercury is. Okay? So at that pressure, your heart contracts, your blood is expelled out of the aorta, and then the pressure starts to travel through the body. And this little niche here, it's called the diacritic notch. It signals that sudden fall in pressure. I like that name, and I remember that name because I always thought it was cool. Like it's like a band, like the diacritic notch. So that's why I remember that little thing here. As the pressure starts to decrease, we start to return to filling of the heart. So here we're expanding and we're filling the heart with blood, called diastole. During diastole, the pressure generated is about 80 millimeters of mercury, and then the process continues, and we keep going through this cycle. Let's say someone's blood pressure is 150 millimeters of mercury. So let's go back to our little square inch. Everyone knows how an inch looks like. Now, instead of 2 pounds, we're applying almost 3 pounds on that little area. And when you do this persistently, that's when damage starts to happen. Let's go into how we characterize or classify blood pressure. So anyone, again, these magic numbers, 120 over 80. Anyone less than that is characterized as normal. People who are hovering above that have prehypertension. And stage 1 and stage 2 are basically indiscriminate of if it's systolic or diastolic, meaning if someone has a systolic pressure of 120, yet their diastolic pressure is 110, they're still categorized as having stage 2 hypertension. Whereas, let's say their systolic pressure is still 120, but their diastolic is 90, they're stage 1. It's either or. Moving right along. So, what are the symptoms of this condition? Right? We have this whole thing that is a risk factor for killing us, literally, and we want to know, how can we monitor that? How can we, assess that? And the answer is that's why this condition is so deadly, because it is the silent killer. You cannot feel that your blood pressure is elevated. What's happening in the meantime? We're putting stress on our target organs, on our organs called target organs, such as our kidneys, brain, eyes, and our heart. Over time, this causes them to deteriorate. I'll let that sink in for 1 second. So, in the kidneys, chronic vasoconstriction of the blood vessels leading to the kidneys cause ischemia. What's ischemia? Lack of blood flow to that organ. What happens? That organ starts to deteriorate. So it's no surprise then that hypertension accounts for 30% of all cases of end-stage renal disease. Really, this simple concept that we're talking about. Physics, right? Decreasing this area and preventing the perfusion of our vital organs. Let's go up to the eyes. This one usually gets people. If you value your eyesight, when we start to damage these vessels in the eyes, these little microvasculature, we start to get blindness and can really severely damage our eyes. Let's go to the brain now. Lack of blood flow to the brain, as you can see in this picture, causes strokes. Hypertensive people are at a 10 times increased risk of stroke versus normal people. So, what does all that mean? Let's put numbers on it. Usually numbers people understand better. So, for every increase by 20 milliliters of mercury systolic or 10 milliliters of mercury diastolic, for every increase above 115 over 75, your risk of ischemic heart disease and stroke progressively doubles. So kind of giving you an idea of what these numbers kind of mean, and we kind of understand how much really is 120 millimeters of mercury. How much are these little units here that we see? Yeah, we see mmHg. What does that mean? Well, like we said, back to that square inch. So helping you kind of quantify these things and putting it all together. So let's go to the treatment. So we see how severe this condition is. How do we target it? How are we going to, either prevent this or treat this? And that consists of lifestyle modifications and drug therapy with the goal of reducing these strokes that we talked about, reducing heart attacks, and organ damage. So let's start with lifestyle modifications. I'm sure many of you have heard of the DASH diet. Usually give them a little dash, and a lot of people don't even know what DASH stands for. DASH stands for Dietary Approaches to Stop Hypertension. As you can see from this table, we have DASH is composed of weight loss, an eating plan composed of a diet rich in fruits and vegetables and low in fat. We have sodium restriction to 2.5 grams of sodium per day. Well, how much is 2.5 grams of sodium per day? That's a half a teaspoon of salt. So, and then fourthly, we have physical activity, which is at least 30 minutes per day, most days of the week. And lastly, moderation of alcohol. Right away, we see that weight reduction has the biggest effect on blood pressure. Okay? Again, going back to this notion of there's this principle that our bodies were built to move. We're made to be dynamic, not to sit all day. And that's why, again, our body responds so negatively when we don't do that and responds positively when we do. So let's go into what moderation of alcohol means. It means less than 1 drink per day for women, or excuse me, 1 or less drink per day for women, and less than or equal to 2 drinks per day for men. 1 drink is 12 ounces of beer, or if you go for the hard stuff, it's about a half an ounce of the hard alcohol. I want to summarize this slide, excuse me, by saying adoption of a healthy lifestyle by all people is critical for the prevention of hypertension. So that's why most, or let's do our case first. So I want to go through a case scenario with you, and then we'll elucidate some of these other points further. So we have this 38-year-old, otherwise healthy Caucasian man who is diagnosed with hypertension. He's enrolled in your hypertension disease management program, and for the past 3 months, he's done these lifestyle changes and this DASH diet with a generous amount of blood pressure reduction. Yet he's still experiencing high blood pressures, averaging 147/85. His primary care physician wants to consider drug therapy. So let's discuss some drug treatment options. So I have this really, really cool diagram for you guys. What this is, we're gonna go through some of the 6 drug classes. There's about 6. And the cool part about this slide is we're going to be able to zoom in on where these drugs are acting in terms of their organs. But first, I want to go through again, or one of the main objectives, which was this concept of myocardial oxygen demand and myocardial oxygen supply. I hope you guys have a better understanding of this now. Let's go through it. So we have this picture of teeter-totter. So we have oxygen demand on the left and oxygen delivery on the right. And these things are in balance. When these things fall out of balance, we get ischemia. What kills us? Ischemic heart disease. So how do we balance this equation? We use things that increase coronary blood flow, thereby increasing supply. What are we doing here? We're widening those vessels. We're increasing, back to the physics now. We're increasing our cross-sectional area. Volume flow rate is directly proportional to that, and more blood gets delivered to the heart. More blood has more oxygen, and the heart is oxygen supply is fulfilled. So we can also use statins, right, to increase coronary flow. Why? Because we have this caking of plaque and fatty plaque actually lining our vessels and causing them to harden. We can give statins to help improve that, thereby again increasing the oxygen delivery and blood supply. Let's go to the left. Balancing this side of the little teeter-totter. The heart contracts. We just talked about the contraction and how we know that contraction requires oxygen, right? Because muscles need energy and they need oxygen to do their job. So we can decrease the heart's demand for oxygen. Now instead of it beating so fast and applying all this pressure and all these millimeters of mercury going crazy, we want to slow it down and have its oxygen demand be less. So now this equation rebalances. We can also use calcium channel blockers. We know that calcium is needed for muscle contraction. So if we block calcium entry, we can also slow down this contractility and this demand. Again, balancing this equation, unbalancing it causes ischemia. Let's go through our drug classes. Let's start in the kidneys. So diuretics. This is the first class. We have about 4 types: thiazides, loops, potassium sparing, and aldosterone receptor blockers. Without going too much into the pharmacology, we know that diuretics, people call them water pills, right? And they're so good at their job because what are they doing? They're decreasing body water. They're helping alleviate blood pressure. Why? Because we have this hypervolemic state, right? We have all this fluid. Back to the physics again. All this fluid in our vessel applies pressure to the vasculature and forces the heart to pump more and harder to maintain that volume flow rate. So what do these do? They relieve the body of this hypervolemic state and help decrease the blood pressure. Basically, what to know about these agents is they're very well tolerated and they can cause some potassium loss. That's why we have potassium sparing diuretics. However, I'll preface with loops, potassium sparing, and aldosterone antagonists are not really used initially for hypertension. They're more used for things like heart failure. So for the purposes of our discussion, thiazides would be more the main treatment option or treatment modality rather for hypertension. These drugs are usually taken in the morning because you don't want patients waking up in the middle of the night, having to go to the bathroom, something we call nocturnal diuresis. But overall, these are really good agents to start with, to start first line. So this is a really good option to start for our patient. Keep in mind that loops and thiazide diuretics, except ethacrinic acid, have this sulfa moiety, and they possess this sulfonamide group. So that's of important clinical relevance for those individuals who have allergies to sulfonamides. So let's go into the lungs now. Let's talk about ACE inhibitors and angiotensin receptor blockers. So these agents act through suppression of RAS. What's RAS? So RAS is this renin-angiotensin aldosterone system. To understand this pathway, you really just have to understand one thing. It looks really complicated, but it's really not. So you see this angiotensin 2 here? Angiotensin 2 is a very potent vasoconstrictor, decreasing our vessel area, increasing our blood pressure. We use ACE inhibitors to prevent the generation of angiotensin 2 and angiotensin receptor blockers to prevent the binding of angiotensin 2. Does that make sense? So ACE inhibitors help make the generation of angiotensin 2 by cleaving angiotensin 1 into angiotensin 2, whereas the ACE angiotensin receptor blockers are going in and preventing the action of angiotensin 2 that's already generated in the body. What to know about these these agents is ACEs and ARBs relatively lower blood pressure about the same amount, which makes sense. Relatively same mechanism of action. They help protect the kidneys. That's another thing to know about these agents. And also may be associated with something called a dry cough, and that's due to an increase in these bradykinin levels, a pathway that we're not going to get into. But if you want to talk about it, we can later. Let's move right along. Let's go to the legs, or the vasculature in the legs, rather. We'll talk about calcium channel blockers or calcium channel antagonists. We have two types, dihydropyridine and non-dihydropyridine calcium channel blockers. To understand what these agents do, again, we have to understand this principle of calcium is needed for smooth muscle contraction in the heart, smooth muscle contraction in the vasculature. If we therefore block calcium entry into the cell, like we do here, here's the calcium channel blocker, here's our cell, here's the calcium entering and being blocked, thereby preventing the heart muscle or the vascular smooth muscle from responding to calcium, right? You can't respond to calcium, your vasculature can't vasoconstrict, and our cross-sectional area therefore relaxes. What side of the equation are we influencing now? The blood supply, right? We're increasing the flow. We're increasing this diameter. What happens if, in our legs, we kind of need this contraction, we kind of need this compliance to be better, and if we're blocking it with these agents, what is a really common side effect with calcium channel blockers? Edema, right? They get edema in their legs. And that's partly due to this mechanism. So what to know about these agents? Again, they can cause peripheral edema and swelling. In angina, the vascular smooth muscle is very sensitive and hyperreactive, and it spazzes out, and it can cause contractions of the vascular smooth muscle, leading to ischemia of the heart, and that causes pain, right? Because when the heart suddenly gets a really decreased supply of oxygen due to this vasospasm of your vessels, you get heart pain, right? Angina means literally heart pain. So we can use calcium blockers as good agents to treat angina. Also, the non-dihydropyridines like diltiazem and verapamil are used to treat arrhythmias because those types of calcium channel blockers also have very good conduction effects on conduction in the heart and can slow that heart rate and that heart rhythm. Moving along, let's go to the main organ, our heart, where our love is, right? In our heart, right? We want to protect our heart. So let's go back to this balance, ischemic myocardial oxygen demand and myocardial oxygen supply. We know that things like epinephrine and norepinephrine help rev our body up. Like they're basically causing our heart to go into overdrive. Like, hey, we have to respond to this. It's our fight or flight. And beta blockers, or epinephrine and norepinephrine, bind to beta receptors. So here's your heart tissue. Here's your receptors. And we see this nerve ending is releasing epinephrine and norepinephrine. Beta blockers come in and block the binding of epinephrine, norepinephrine, thereby slowing the heart's what? Demand for oxygen, right? Because now it's the signal of, hey, let's go, rev up, let's keep going, is gone. So beta receptors help decrease the heart's rate and contractility via blocking these beta receptors in the heart muscle. And also there's also in the blood vessels, there's also beta receptors in the lungs. And that's why in patients with asthma or severe chronic obstructive pulmonary disorder, or disease rather, these agents should be used with caution, especially the non-selective agents, because they can block these beta-2 receptors in the lungs and cause problems for these patients. We'll go into this point further. These agents are not necessarily recommended first line, and when we get to the guidelines, we'll go ahead and see why. So let's move to the vasodilators. This class of drugs should be the easiest to understand, because when we talk about our physics, we're talking about this volume flow rate and how our radius is directly proportional to that. If we increase it with vasodilating drugs, we thereby increase our diameter and more blood flows to the heart. So we're influencing that right side of the equation, rebalancing that ischemic issue. Why is that important? Because ischemic heart disease is the top leading cause of death. So what to know about these agents? Mainly you might see hydralazine. Hydralazine has a very short half-life. This drug is used or given at a very high frequency, almost 4 times per day. And then you have agents like minoxidil, which are reserved for patients who have more severe or symptomatic hypertension that is not manageable with a diuretic plus 2 other antihypertensives, more towards the last line of therapy. Overall, these drugs lower blood pressure by exerting a peripheral vasodilating effect through direct relaxation of these vascular smooth muscles in our body. So let's go to the brain now. I don't know if you guys saw that this group of drugs is in the brain. So we're going to talk about alpha agonists. So this is the last class of drugs we're going to be talking about. These drugs reduce sympathetic outflow. They work in the CNS, in the central nervous system. Remember how we talked about the beta blockers and how norepinephrine and epinephrine are being released into that terminal, and their binding causes the transmission of our flight or flight response, right? This part of these type of drugs start way up in the brain. They prevent that signal from being even generated, right? So they agonize something called alpha-2 adrenal receptors in the brainstem, which result in reduced sympathetic outflow. So this signal of, hey, let's rev everything up, is being inhibited or being stopped or being slowed. The overall effect, therefore, is reduced norepinephrine release and decreased blood pressure. What to know about these drugs is, for example, clonidine is associated with rebound effects. Rebound hypertension occurs when you have this drug that's decreasing your blood pressure, and when you abruptly stop it, you have the opposite effect occur. So if this blood is decreasing your blood pressure and you abruptly stop it, now you're going to have a surge or increase in blood pressure, a rebound effect. That is why clonidine should be tapered off. So I hope you guys enjoyed this depiction of how the classes are working and where they're working in the body. I want to go here to this table now so we can put all this together. Let's put all this stuff that we just talked about together. This table shows the blood pressure reduction. This table shows the blood pressure reductions of the therapies we've just discussed. And right away, what do you notice? The DASH diet lowers blood pressure almost as much as drugs do, if not a little bit more. Again, that's why diet, exercise, having a diet rich in fruits and vegetables is so important. And that's why a lot of disease management programs are so successful, because this doesn't need drugs. And this influences blood pressure so immensely. So programs that do this are relatively successful because of how effective this type of therapy is. So let's go back to our patient. We remember that we need to pick a therapy for him. So just for the sake of this discussion, for now, let's just pick the best drug on this table. And the best drug would be a thiazide diuretic. So you'll find that the JNC8 guidelines, newly published, also agree with this recommendation that a thiazide should be started as first line. However, I want to preface with that Dr. Larnois, our medical director, will be going into much more detail into the new JNC8 guidelines. And, Dr. Larnois is a man that I really respect. I really respect his opinion. And I'm just very happy and excited that this series can continue with his insight. With that said, let's go into these guidelines. So the main message that they wanted to do in these guidelines is they wanted to make the message very simple for physicians. They wanted to say treat everybody to 150 who is greater than 60 and 140 over 90 for everybody else. Really simple message. Again, treat the 150 for people over 60 and 140 over 90 for everyone else. So we remember that our patient's blood pressure was 145 over 87, so he's not at the appropriate appropriate goal relative to these guidelines. So how should we treat him? Well, these guidelines narrowed down the categories to 4 recommended categories. And I have these tabulated in this table for you. As you can see at the top, in orange, the hypertensive medication choices, and in red are the goals with the evidence grade here. The 4 recommended classes are thiazides, calcium channel blockers, ACE inhibitors, and ARBs. So we know that the objective of hypertension is to treat and to attain and maintain this goal blood pressure. If it's not reached, recommendation number 9 in the guidelines says go ahead and max out the dose of the initial drug and then add a second one from the recommended categories to elicit this goal blood pressure or reach this goal blood pressure. So these categories, again, are very important because, and are the only 4 categories that were recommended in this guidelines because they have comparable and positive effects on mortality outcomes. And we're going to go through that in a bit. So I just want to first touch on the main highlights of these guidelines. Again, in the next part of the series, Dr. Lano will be going into depth in these guidelines. They were based only on randomized controlled trials, and we know that RCTs are the gold standard because they are really strong predictors of efficacy and effectiveness of drug therapy. So these are the only types of trials that they used. They eased up on the blood pressure goals. For example, in patients with diabetes, instead of less than 130 over 80, they say 140 over 80. And again, the main highlight is these 4 recommended drug classes because of their beneficial effects on mortality, cardio, and cerebrovascular outcomes. And these classes were not, the other classes that we went through were beta blockers and alpha agonists, etc. Those classes were not included because in the 4 recommended classes because no randomized controlled trials of good or fair quality comparing the following to the 4 recommended classes, we're done. Therefore, these drugs are not recommended as initial treatment. So what does this all mean? I have a really nice algorithm here to help us treat our patient. So I really like this. This is from Pharmacist Letter. It's done by Dr. Melanie Cupp. She's a pharmacist there. I think this algorithm is great because, it simplifies everything. So we start with lifestyle changes. Our patient is less than 60. Their blood pressure is 145/87. So we go over this side. We start pharmacotherapy. Remember, he's Caucasian. He's otherwise healthy. So we can start any one of these drug classes. We chose a thiazide. So we'll go ahead and wait if he's not at goal. In about 2 to 3 weeks, we'll assess lifestyle, increase the dose if we need to, or add another one of these recommended drug classes, ACE, CCB, or ARB. We'll monitor that, and if these options have been exhausted, we can consider other drug classes that we spoke about. So last thing to note on this guidelines slide is that the AHA and ACC guidelines are hopefully to be published in 2015. So I'm excited to see what their opinion on this is. So we know again that the objective of blood pressure or hypertension therapy is to maintain and attain this target blood pressure. And we know that everybody's different, right? So blood pressure goals should be individualized, right? Because we're all different people. Although blood pressure recommendations vary across the available guidelines, here at American Healthcare, we adhere to the stricter guidelines set forth by the ACE, for example, because we believe that some of these pressures, especially for patients with diabetes, are more reasonable. So, for example, someone with uncomplicated hypertension will treat to a goal of 140/90, whereas if someone has heart failure, we will aim for less than 120/80, and similar with diabetes. Moving right along, let's say our patient is still resistant to therapy. We exhausted all these measures. What does resistant hypertension mean? Some people use this term incorrectly. Resistant hypertension means failure to achieve blood pressure goal in patients adhering to full doses of a 3-drug regimen, and that 3-drug regimen has to include a diuretic. So, what is at the top of the list? We see, boom, volume overload. Let's go back to our physics again. Too much volume, more pressure needed to push that or propel that volume through the body. So excess sodium intake, water follows sodium. The more sodium we have, the more water we retain. Also things like drug-induced causes. Sometimes these things are not addressed and new drugs are just added. So non-adherence, inadequate doses, inadequate combinations, and also something that's also relatively benign are NSAIDs, things like ibuprofen. Well, that's a cause of resistant hypertension. Why? Because that also causes sodium and water retention. Corticosteroids are also an issue as well. So all these things would be something I would think, to take into account first. But, if a patient is having resistant hypertension, these are things we can kind of consider and make sure that we check off our list. Lastly would be obesity or things like excess alcohol intake that can cause this blood pressure or this resistant hypertension. Excuse me. So I really like this slide. I put this in here because I think it makes a lot of sense. This is something called nocturnal therapy. So in this study by Mantulo and colleagues, it was in patients with CKD, we know that the average blood pressure is approximately 15% lower than daytime values. Nocturnal blood pressure meaning while we're sleeping. And that makes sense because our sleep, our body temperature, our metabolic rate, they all go down when we sleep. What does that do? That helps our vasculature relax, helps it take a break, right? Where our blood pressure is so high during the day, at night we need to dip, is what they call it. So dipping is when your blood pressure falls by 15% or lower than daytime values, and non-dipping is when your blood pressure fails to fall by at least 10% during sleep. Why am I talking about this? Because non-dipping is a stronger predictor of adverse cardiovascular outcomes than daytime blood pressure, is what was found in this study in patients with CKD. So what does that mean? Well, we can possibly generate intervention from this, right? We can possibly shift one antihypertensive agent drug from the morning to the evening, restoring this normal nocturnal blood pressure and thereby decreasing our 24-hour average blood pressure. Again, very cool study. I think that makes perfect sense, and that's why I wanted to include that slide in here. Moving right along. So what should we tell patients, or what should we tell our patient? Well, we want to make sure that he knows or understands that hypertension is a silent killer and that he needs to continue his treatment, and that controlling his hypertension to this goal blood pressure does not necessarily mean a cure. We'd also help him incorporate taking his medications into his habitual regimens, like taking it after you brush your teeth, or using a pill box, etc. So what is the big picture? How can we really make a difference? In anything I do or in anything I learn or study, really, I always like to think about the big picture. What is really going on here? I really, really love this slide. It was presented in the World Economic Report, and then also presented on Hewitt's 2012 Healthcare Survey. What this shows is the 8 risks and behaviors: poor diet, physical activity, etc. They're saying these things drive the 15 chronic conditions that account for 80% of total health costs for all chronic illnesses in the world. Does this make sense? Yes. Insufficient sleep, excess alcohol consumption, poor diet, physical inactivity, poor stress management. All these things lead to risk factors that what? That kill us. Risk factors that cause death. The beauty of this slide and the beauty of managed care is that all these things are preventable. We can prevent this. And that's why I love this slide so much, because we have these risk factors that put us at risk for death, and we know the main causes of death are ischemic heart disease, killing about 7.4 million people in the world in the past decade, and it's been that way for the past decade. And again, I can't stress how much I love this slide. So, in conclusion, we talked about the number 1 risk factor for heart disease being hypertension, and how hypertension is the silent killer. We talked about the importance of lifestyle and hypertensive treatment, and these 4 recommended drug categories that benefit our mortality and our cerebrovascular and cardiovascular outcomes. We also talked about this balance, this equation between myocardial oxygen demand and myocardial oxygen supply, and balancing that equation helps prevent ischemia, right? We also went through some of the physics of that, of what blood pressure really is, what's really happening, because some people never really think about that. Lastly, we talked about this resistant hypertension. When someone's hypertension resistant, what can we do? And lastly, these 8 risks and behaviors. So thank you for listening to this presentation. I hope it was helpful and informative, and I hope you guys learned some interesting things along the way. With that said, I will entertain any questions if I am able to answer them. My throat's really dry. Okay, if there's no questions, then we can go ahead and wrap it up. Thank you all for listening. We can give a second for anyone who's has any thoughts. If not, thank you guys so much again.